G'day, Sean again, and we're just going to almost wrap up this part of the subject and look at other moral theories and influences on healthcare ethics. It might not surprise you that we haven't actually covered all the moral theories, all the different philosophical points of view that relate to bioethics and healthcare ethics. But I thought I'd just cover a few more of the other emerging and common moral theories and influences on healthcare ethics, because the field is really still evolving. Now, the field of bioethics is tending to a more what we call a bottom-up approach rather than a top-down approach. Now, what this means is rather than apply abstract theories from a bunch of dead philosophers, which would be the top-down, the idea is to develop pragmatic solutions in a collaborative or pluralist way. So that is using many sources and many influences and collaborating with as many people as possible, so that problems and differences of opinions can be solved. And this is the bottom-up approach. It's more of an organic, granular, at the site approach. One of the more recent approaches is something that sort of parallels the development of legal reasoning. And this is a concept called casuistry. Now, if you hear the word casuistry, you mainly hear it in the legal sense, but it's also a bioethical approach as well. And all it really means is case-based reasoning. So it's really similar to the legal principle of precedent. It's really similar to, I guess in this year, most of you will be studying nursing, and you're going to go through a lot of case-based clinical problems. All right, so it's really similar to that. It's using what has worked in similar cases before to use as a precedent to apply in a case now. Now, it does, like anything that we talk about in ethics, it has its objections and people who don't like it. And one of the objections is that it depends upon the clinician mainly in making these judgments. And the thinking is that it may lead to a persistence of paternalism, which has dogged healthcare over the last couple of centuries. But many defenders consider that it works best if using like a common morality. It's the principles of common morality. And really, this is what principlism is, isn't it? So if you stick to those principlist ideas, not like glue, not as rules, but if you use those as a basis or a guide for good judgment, the thinking is that casuistry has many strengths. And you might see it used, if you work in an intensive care unit, for example, with end-of-life issues, casuistry is a kind of process which I think is used fairly commonly, because we see many of the same types of ethical concerns popping up regularly. So an established way of dealing with something becomes like the norm. It doesn't mean it can't be critiqued, or that it might be perfect, and it cannot be changed. But, if there's good reasons to do something, then why change it unless you have to, I suppose. All right. Now, feminist ethics and ethics of care is really big influence right now, and has been for at least 20 years. That's been discussed already. So we'll look at rights theory or human rights theory. So you hear a lot, and you would have heard a lot already in healthcare and in other disciplines about universal human rights. So it's not entirely new. And Western nations have had bills of rights since the 17th century. Britain's had a Bill of Rights since then in its constitution. But a universal declaration of human rights was born out of the Holocaust in World War II. So this emerged in 1948. What are rights, though? Well, they attempt to articulate basic claims that persons can make upon other individuals and also upon society. There's two main types of rights. They can be articulated as negative rights, which means freedom from something, such as freedom from oppression. So liberty is a type of negative right. It's the negative right to be free from oppression. And there's also positive rights, which require the provision of something to work. An example of a positive right is access to healthcare. So it requires someone giving you healthcare for that right to be enacted. So you can see from this that from rights become obligations and duties, and also from rights comes concepts of distributive justice. I've already talked a little bit about this distributive justice, and you'll see this in other subjects. What that means is how to ensure that other persons in society have access to healthcare, for example. Now, rights are also articulated in healthcare, and patients have rights. So we will look further on in the subject at a thing called the Australian Charter of Healthcare Rights. So all patients have a charter of rights that we as clinicians adhere to. Now, in a similar way to principalism, rights are strongly protective for persons. They protect citizens from the excesses of the state and oppression from the state. And they're also designed to protect against things like paternalism in healthcare. But they spring quite strongly from the philosophy of libertarianism, which privileges the autonomy of individuals. And this has some negatives. Now, we've seen in the COVID response, strong libertarians have resisted mandation of vaccines and also lockdowns to the prevention of COVID. And it's really interesting to see the United States, which has a far longer and stronger history of libertarianism, has had fewer controls to manage COVID and correspondingly a massive mortality rate from COVID. So libertarianism, when applied really strongly, certainly has its limits in efficacy for communities. So the opposite of libertarianism is communitarianism, which emphasizes the community, it emphasizes cooperation, and also privileges a thing called the common good, which is almost like utilitarianism. It's what is best for all people, for human flourishing as communities. And the hope and the feeling that if communities are strong and are flourishing, individuals within that community will be flourishing. So in communitarianism, individuals in society are expected not to emphasize their own liberty, but to work for the good of all, which ultimately will work for the good of all or in favor of all individuals. Communitarian arguments are also arguments of justice, or what is fair. And you'll see them playing out right now in discussions over reproductive technologies, for example. All right. Another thing which I've seen emerging in my time in studying ethics is empiricism. I've talked about empiricism before. Empiricism is just a fancy word for using evidence over pure reasoning. So it's when you look at things like statistics, you look at psychology, you look at evidence-based medicine, evidence-based nursing, evidence-based health. You look at other fields of study such as sociology, for example, and you use those in the process of applying ethics. Now, this is really controversial for philosophers because there's a famous distinction that we make that goes back a few hundred years, a famous distinction that we make between the way things are and the way things ought to be morally or ethically. And that distinction is called the is-ought distinction. And you can't get ought from the is. Now, what I mean by that is just because we do something doesn't mean that we ought to do something, all right? The ought, or the moral commands or the moral reasoning should become purely from the moral calculations. Okay, so just because we do something, for example, slavery, and it seems to work for us, doesn't mean that it's something that we ought to do. All right, so empiricism is a little bit controversial because it's starting to bring in, well, and I like empiricism. As a nurse, I'm all for evidence-based practice. Empiricism, what it does is it looks as, well, do actually the moral decisions that we make have a good effect? So there might be reasonable moral calculations, but if no one's happy about them, are they really working and are they really moral? So it's quite challenging to, I suppose, more abstract or ivory tower philosophy department academic types of ethics. And my ethics lecturers will hate me saying this because most of them are grounded very much in pragmatics, but it's sort of the opposite to the applied or the practical approach of ethics. Anyway, so it's becoming a lot more dominant now, and it principally relates to descriptive ethics, or what people do and what people think. So personally, I find this really interesting. It can't be used as a means of making moral judgments, but it is always important to see how people, particularly our patients and families and ourselves, actually think and feel about health ethics that affect us and affect our patients. And I'll give you an example which might illustrate this a little bit. Now, despite the principle of respect for autonomy, and you're going to see this more and more over the next couple of years of your nursing degree if you're studying nursing. Now, despite the principle of respect for autonomy, which is so fundamental, it springs from this libertarianism, spring from this, this really strong focus in Western health and Western ethics about autonomy of self. All right. Now, despite that, and despite the legal principle of informed consent that derives from that, empirical research, so actually studying patients, shows that many people don't want to make decisions for themselves. Many patients do not want to be informed, and many are perfectly happy and would prefer to have experts, you and I, and physicians and doctors, make decisions for their best interests. All right. Moreover, clinicians themselves report that informed consent is actually more about a box-ticking exercise than a valid communication between a physician and to the patient. So this is really challenging, I think, not so much for, well, also for the legal principle of informed consent, but for the ethical principle of autonomy. You know, what if the patient doesn't want autonomy? It's really, really interesting. So I think that it's a way of always, scrutinizing what we do, always applying, an evidence basis even to moral theories that we use. So I think it's a really powerful tool, and you'll see this maybe used more and more as you practice as a clinician. All right. So ethics is really hard, isn't it? There's a bunch of principles and theories out there, but how do we apply them all? It's a little bit like evidence-based practice. There's often more than one way to achieve an outcome, and often the decisions might even conflict with one another. So are we any closer to being prepared to make hard moral decisions at the bedside? Well, don't worry. The next lecture, I'll discuss a tool for moral reasoning and give you maybe some guides as to how this may be done pragmatically.